All right. Hello, everyone. Thank you for joining us this evening. My name is Alexis Davis, and I'm the social media manager here at RSDSA. I'm joined by Jim Broach, Executive Vice President and Director of RSDSA, and Dr. Louis Siegelman, who is our guest this evening. So Dr. Siegelman is a dentist anesthesiologist with a dental practice in NYC focused on the treatment of dental anxiety. In addition to maintaining a private practice, he is involved in teaching, resident training, and education. Dr. Siegelman is Assistant Director of the Dental Anesthesiology Residency Program at NYU Langone Medical Center and Clinical Assistant Professor at NYU College of Dentistry. His practice and career as a dentist is devoted to helping people with dental phobia and special needs. Now, please remember that while the information shared here tonight is helpful, be sure to consult your medical professional for personalized medical advice. Now, Jim, is there anything else that you want to add before we turn it over to our guest?
I would like to just announce a couple activities that were coming quickly. This coming week, we're going to publish our first electronic newsletter for the RSD Community Update. And if you are not a member, please go to our website at rsds.org and just join. There's a big join us, and it's free. And the newsletter will be delivered probably midweek. Secondly, we're going to be hosting our inaugural virtual walk in August on the 22nd, and that's coming up. And like so many other not-for-profits, we really can't do face-to-face activities at this point. Another thing that's happening right now is Eric Morrell, who last year biked from Massachusetts to Florida, stopping along the way to visit people with CRPS. He's on a virtual tour right now, and he's going, is he going to Maine? Portland, Maine, I think he is.
I believe so.
I think so. And you have to check them out. And then finally, that we're excited, we have another exciting speaker on the 16th of July, and that's going to be Dr. Michael Cooney, and who is treats people with CalMare, and he has treated over 1,000 people with CalMare from around the world, and that's going to be exciting. But today we're really excited. So many times we have questions about dentistry and CRPS and the fear of that dental procedures and will really make CRPS worse and make spread to the face. So we're so excited to have Dr. Siegelman today. And thank you, Alexis.
All righty, so let's go ahead and get things kicked off. So I'm going to go away and then get this presentation queued up. All right, Dr. Siegelman, it is all you.
Okay, good evening, everyone, and I am just so thrilled to be here. I really appreciate the invitation, and I really appreciate the opportunity to speak to all of you out there who are in pain and need help and have worries and concerns. And to whatever extent I could answer them or help you, I'm thrilled to do that. And my contact information is at the end of the presentation, but feel free to call me, contact me, email me, and I can hopefully put you in touch with people in your own area. I know this is really around the world. Mostly I know people, of course, in the United States, but I would be very happy to be a resource and happy to help anyone that I can. My practice really centers on people who have trouble going to the dentist for really any reason. And so I'm actually a dental anesthesiologist, and that's a new, exciting specialty in dentistry that the American Dental Association has finally recognized. And that's only really in the last maybe a little over a year. And then just even more recently, just really within the last few months, they recognized a specialty of facial pain. So there's really two new dental specialties that relate to relief of pain and anxiety, which is amazing to get that recognition through the American Dental Association, and it wasn't easy. It really took decades. So my practice really is centered on creating a home for people, and over the years, it's really grown to include more and more modalities. What's really important in the care of somebody who has difficulty going to the dentist? So I think that over the years, I've really added pieces on nutrition and home care and prevention, as well as the therapy and providing different therapeutic modalities. So I feel like it's a comprehensive program now, and I just want to share aspects of that with you. So it's non-pharmacologic and pharmacologic. And I'm going to take you through mainly the non-pharmacologic in the beginning, and then we'll get into the more of the pharmacologic techniques and what the approach is. But we want you, wherever you are in the country or the world, to be able to give you guys the tools to find the right people, the right healthcare providers for yourselves, and so that you could get this locally. But if you need me for any reason to make a referral or for information or just as a sounding board, I'll be happy to speak to you or put you in touch with one of my professionals or a related professional that could help you. So away we go. One of the main things that CRPS patients tell me is that they are so concerned with this spreading, and that's a main concern. And so people are so concerned with having a safe environment and finding this home, and often that requires trust. And so we want to really create an environment of trust. And now, of course, we have COVID to worry about. So that's a new layer. If you look at the picture on the left, you'll see this funny blue light up in the top left-hand corner of that picture. And then toward the middle on the top, you'll see this stripe of blue light. And so one of the things that has been found to be effective against COVID, the coronavirus, is UVC lighting. So this is UVC lighting, and it actually creates a zone of disinfection near the ceiling, and that kills mold, bacteria, viruses. And then we use an air circulator, we use an air sanitizer to circulate the air in the room past this upper air zone of UVC lighting. So this is kind of an advanced system. You might see this in kidney transplant units or any kind of a unit where people have lowered immunity. So it's a cool thing, and I think that you might be finding this more and more in public places where we need to make this safe. So next slide. So it's this whole question: can CRPS spread to the face after dental care? And there have been studies to this effect, and on the spread of CRPS, and usually affects one limb, of course, but it can spread to another limb or spread in the same limb. So it can happen. It can happen. In my experience, I have not had this. I've treated maybe 10,000 people over the years, a lot of people, with many of whom have chronic pain, and I have not had CRPS patients with spread after dental care. In my field, I really am focused on acute management of pain and post-op pain. That's really, from the pain perspective, that acute management allows me to really throw everything I have or everything that's available at pain. And so that's an advantage. It's not what you could do day after day after day, but you can find people who know a lot about controlling it in the acute moment. So we do have these two new specialties, and now you can contact your local dental society and find out what people are recognizing that specialty in your area. So I think that would be a great thing. And there is a risk of patients developing secondary CRPS with or without an inciting event. So sometimes it can happen. In my experience, really optimizing the patient and getting them in a really good condition for this for their care is paramount. And whenever you're going for a procedure, you should definitely feel that you're at your best. Don't go for an elective procedure when you're really not feeling your best. If you're in the middle of a flare, that's not the time to go. You really want to go when things are good, and it could be best managed. And I personally have had severe neuropathic pain. I don't meet the diagnostic criteria for CRPS, but I know what that pain is. I know how unrelenting and sharp and severe that pain could be. So when you're in a good moment, don't go. When you're in a good moment is the time to go. And one of the things that happens with people who have chronic pain is that they are so sensitized. And frequently people will ask me, they'll say, "Doc, is this something that's going to hurt afterwards?" And I would say for an ordinary patient, it probably would not. But for somebody whose nerve endings are so sensitized, yes, this could potentially be a pain that will last. But we take we do everything to minimize that. So we throw everything at it, and I'll go through that a little bit later. Next slide. So one of the really interesting things in preparing for this, I did come across on the nationalpainreport.com, submitted by Jenny, as mentioned above, vitamin C, and that this can prevent CRPS so you could use it as a preventive measure. And the study suggests taking 500 milligrams for 50 days after surgery. And they did study this in wrist surgery. I don't have that reference here, but I've listened to lectures where credible people have also referenced this. So I would encourage anyone with CRPS who's contemplating any kind of a procedure to investigate this. The scientific literature that supports this. So frequently vitamins can get it's not something that's controlled by the FDA, and so it's not as proven as other medications. But I would look into this. There's definitely scientific research that this is something that's effective. So that's a great thing. Having a tool to prevent CRPS from a procedure. That's awesome. Next slide. So now we have COVID-19. And so this is an additional factor to consider because CRPS affects the immune system, and we really need to boost our immune system at this point. And CRPS patients have high levels of inflammatory chemicals, cytokines, and these have been found in tissues of people with CRPS. And that is one of the key elements of COVID-19, that people get sick. Frequently it's upper respiratory infection, lower respiratory infection, and then they develop this cytokine storm, this storm of a release of inflammatory chemicals. So people with CRPS already have high levels of these. Now, I don't think that there's any published research that I've seen about CRPS and COVID-19 specifically, but I think that we want to control this as much as we possibly can. Next slide. And one of the things that I think is concerning. So I was speaking before about people with chronic pain in general, and in my research, I find that there are reports coming out of post-COVID syndrome, long-lasting effects from COVID, from coronavirus, and some of these are neurologic. And so there is an increase in peripheral neuropathy related symptoms. And I would suggest that it's only reasonable to assume that people with a sensitized nervous system after COVID-19 will have symptoms. And this is something that's very common in viral illnesses, where for years, for many years, it would happen as an isolated thing. The patients would come in and they would say, gee, I don't have a sense of smell, I lost my sense of taste, and we really would not know, would not be able to assign a direct cause, and it was always assumed, for the most part, that it was viral. So I think that patients with CRPS, and if they do unfortunately get COVID-19, I would expect some exacerbation of their symptoms based on pre-existing sensitization of the nervous system. So I think that would be expected. So we really have to, it's even more important for CRPS patients to protect themselves from COVID-19. And I think that unfortunately it's going to be around for a while, and we're all going to have to learn to live with this. One of the best references that I've seen, I follow a number of sources. One of them is Michael Osterholm, and he's head of the Center for Infectious Disease Research and Policy at University of Minnesota. And he's a very forthright, straightforward talker, and he has a weekly podcast that I think is valuable to healthcare professionals and the lay public. It's just really straight talk. This is what we have to expect, and this is how we can best muddle through. But it's definitely going to be around for a while. So when patients come in with CRPS, they usually have a long list of medications that they're on, medications that they've tried, healthcare professionals that they've been to, and it's generally a long journey, and it's hard for dentists to really understand all this and to assimilate all this. There's so many different doctors, so many different medications, and for a dentist to understand how this is going to impact their care. So to whatever extent you can, I would have a detailed written narrative of your history, and then just update that. And then you can forward that to your healthcare professional, your dentist or other healthcare professional before you visit. So they have everything right there in front of them, because it becomes very difficult and time consuming to get all this down. And one of the things that I want to understand is I want to understand how the CRPS originally happened, the dates of surgeries, who the other healthcare providers are, so I can contact people who may know more about you than I do. And so if I could contact somebody who really, a healthcare professional who really knows about you, that's going to really help me understand you much better and be able to provide you with care. And I may need backup. So if you have a pain management specialist and you do have some flare or exacerbation, this is somebody that I've contacted in advance, told them what we were up for, and you've discussed this, and this is your team, and now we can move forward with your care. And I did see on the RSDA website that the RSDA has really done a great job of putting together a pre-prepared sheet like that. And I think that was really a great resource. And I would definitely encourage everyone to look at that and to find that on the RSDA.org website and download that. And when you're going to a new doctor, or even if it's your regular doctor, definitely submit that. Next. And so here it is. This is everything that's on there. And it's the dental guidelines for CRPS RSD patients handle with care. And I think that you don't want somebody who really has never handled a CRPS patient before, who may take this condition for granted. And you want somebody to really respect what you've been through, and somebody who is going to handle you very delicately, and handle and sometimes healthcare providers, I don't have to tell you guys, could be rough. They could not be gentle with tissues, in how we maybe it's just how we take the mirror in and out of the mouth, just how we may handle the suction. You want somebody who really respects the soft tissue and is going to be very gentle with that. So I love this resource. I really I looked at it, and I included this in my presentation before I found this. But once I found it, I really thought it was spot on. So kudos to you guys. And it really starts with listening to the patient and understanding their needs. And the fascinating thing is that people use language. They use very specific language when you listen to them. And one of the things that people will always say, my healthcare provider didn't really listen. But I always found that it was hard for me to know what the best care to provide was if I just had to look myself without clues. So I always wanted these clues. And after a while, I discovered that if I simply listen to the patient will very frequently give me the correct diagnosis. They'll tell me whether it's a dental pain, non-dental pain. They'll tell me by their symptoms whether it's root canal, gum, sinus, all of the above. So I really need to listen to the patient so that I could get my diagnosis. So people will use, maybe they're going to use a language of pain. Not for most people, the local anesthetic is great. It's extremely effective, and for most people it works great. Probably for about 95% of patients it works great, but for about 5% of patients it doesn't. It really doesn't work that well. And in that 5%, it's a spectrum. Maybe some people, they just really don't get Nmda. You give them the local anesthetic and they really still feel everything. For other people, it just takes longer for it to take effect. And for other people, it just wears off incredibly quickly. So listening to the patient and hearing that language of pain. They had to give me 8 injections. I still felt it. And sometimes doctors will deny that pain. In other words, from the doctor's perspective, they're giving the patient this magic liquid that is supposed to make the patient numb, and yet it just doesn't seem to be working. So the doctor may not have any other tools in their toolbox to help this patient, and they're only human. What they unfortunately do sometimes is blame the patient. They might say, that's not pain that you're feeling, it's pressure, that's your anxiety. But sometimes the local anesthetic is simply not that effective. And we're going to talk about what other pharmacology and what other modalities we could bring to bear on that. Other patients use language of anxiety. My heart pounds, my palms sweat, I can't go to sleep the night before. I haven't thought of anything. I can't do my job for 5 days before the appointment. And so they're using a language of anxiety. And I know that those medications, I have to address them differently. Maybe I'm going to rely on benzodiazepines, which are Valium and all the relatives, Ativan, lorazepam, Xanax, whatever relatives in that family. But I know that I need to use anxiety relieving drugs because that's what they have. Other people will say, and I'm questioning them, I'm listening to them. They're not using a language of pain. They're not using a language of anxiety. And I say, so what is it? And they'll say, I don't know, doc. It's the sights, it's the sounds. So they're using the sensory language. And there's a term called sensory integration dysfunction, which usually we think of people who are on the autistic spectrum, that they have the sensory integration dysfunction, and they are hypersensitive to smells and tastes and vivid visual things and the noise of the drill. So we think of people on the autistic spectrum. However, there's many people. It's extremely common for people who are not on the spectrum to have some sensory issue. Maybe, you're not calling it sensory integration dysfunction. Maybe you're calling it a musical ear, in a positive sense, or an exquisite sense of smell, the nose. So we can look at it different ways, but some people are very, 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 very sensory. And I asked a wonderful patient of mine who has CRPS, and I took care of her this week. I hope you're out there. And I said, so tell me what people need to hear. Tell me about what I should say, or what issues I should address. And she said, people with CRPS, we are very, very, very sensory. And all these vivid visual, smell, noise things, it raises our pain perception. So it's just another group that is really sensory sensitive, and I think we can address that as well. So we're trying to find out what the patient's concerns are, and when I listen to this language, this is what tells me how I can approach this patient. So they're really a pain patient. They really have anxiety, or it's really sensory. And so I now I know what I'm treating, and now I'm going to look at the dental side, and I'm going to see, well, it's very simple what they need. There's a simple dental procedure, or there's multiple invasive dental procedures. And so I'm going to put those two things together: the patient's language, their needs as a human being, and their dental needs. I'm going to put all that together, and that's going to give us the treatment plan. Then I'm going to review that with the patient and see what they have to say about that. And I'm going to outline the patient's what modalities are available, and then they're going to tell me, gee, doc, put me out. You got to put me out for this. Or they may say, no, I don't need that. As long as somebody's listening to me, and we can do these minor, minimally invasive things, that may be what they're looking for. So I'll put my stuff together, the dental side, the human side, present it to the patient, hear what their concerns are, and then come up with a final plan. That's basically how it works. Next. So, when you're dealing with people who have difficulty going to the dentist, you really want to think upstream. How can we solve these problems for people upstream? And people who have CRPS, people have chronic pain, people have a lot of health or medical issues. You really don't want to get too fancy with them. You don't want to over treat them. And as a healthcare professional, over treatment really bothers me. I feel like we need to help people be healthier rather than treat the downstream after effect. And for somebody who has difficulty going to the dentist, maybe I'll never be able to catch up. I'll never be able to do all this treatment that they need. So the only way that I could help them be healthy is thinking upstream, all the way upstream, so that people don't develop cavities, or at least if they have them, that now we can stop it, we can freeze that in time, and now we can just catch up, and then they'll be healthy. And so that's really what we want to do. And what I find is that, and I had a patient like this today, where people think that they're doing things that are helpful for themselves. They want to be healthy, they're proactive, they're reading on the internet, and they just, the internet is a strange place, as we all know, and they just get into a product that isn't really helpful for them. And so what happened today, I met this woman a couple weeks ago, and I treated her today. And usually it's beverages that cause tooth decay. And as a matter of fact, people very often, maybe 2-3 times a week, people come in and they're sure that they have cavities, and because their teeth are so sensitive, and yet they have no cavities. It's just all these beverages, these acidy beverages, that really sensitize the teeth, and people think that they have cavities. And for the woman who I saw today, she got this really great all-natural toothpaste, and she had a lot of cavities. And we went through what she's eating, what she's drinking, what could be causing this, and she didn't really give me much that I would say, gee, I bet that's where your cavities are coming from. And finally, usually my third line of questioning, tell me what toothpaste you're using. And she was using an all-natural toothpaste without fluoride. And it's very easy on the internet to find negative things about fluoride. But I can tell you that when people don't have fluoride in their toothpaste, they will get cavities. They'll get 3, 4, 5, 7 cavities. And a lot of times these are people that I've been taking care of for years. I know them for a long time, and they never really get cavities, and everything is great. And then they'll come in and I'll see they have a few cavities, and I know they're doing something different. And I'll ask them, what is it? And they'll usually tell me that it's some, really all natural thing, doesn't have fluoride, and they start to get cavities. And so I'll identify this with them. Usually I'll put them on a high fluoride toothpaste, and you could tell the difference. The tooth surfaces, the root surfaces in particular, they're a little soft. Like they just give you the feeling that there's a little something soft about them. And when you put them back on the fluoride, particularly a high fluoride toothpaste, particularly a remineralizer, all of a sudden that you could detect that the surfaces of the teeth the enamel is more lustrous, and it's just harder. And you could tell that it has more mineral content. But even something like, what does everybody drink nowadays? Everybody is drinking the Soda Stream or all these sparkling beverages, and even those can really produce a lot of sensitivity. So you have to be very careful. The other really interesting thing is that when people sip these things all day, so oftentimes I'll say, you have coffee, you put sugar in your coffee, and they'll say, yeah, I put sugar in your coffee in their coffee. And my next question is, how long does it take you to finish your cup of coffee? And if they say, I work construction, I have to slog it down, I just have 5 minutes in between, for a break, that's basically one assault or one application of the sugar on their teeth. But if they say, I love my coffee and I sip that all morning, it takes me all morning to finish that cup. So what happens is that little sip is another application of sugar on the teeth. And so now, for a long period of time, a lot of the day, the sugar coating the teeth, and that'll get tooth decay and bring about tooth decay. And a lot of times, people have their favorite thing. They really don't want to give that up. So what I've spoken to people about is a sipping beverage versus something they might have at mealtime. So let's say, Doc, I love lemonade in the summertime. I just love a lemonade with my chicken in the evening for dinner. And they may not really have to give that up. But what I tell people is just drink that and with your meal and be done with it. Because there's probably vinegar on their salad and acidy things in there in the sauce. My wife is downstairs making her sauce. So that's what I'm doing after this, by the way. So, maybe there's an acidy, tomato sauce, which could be really delicious. But so there's loads of acidy things, when you're having your meal. So just have your acidy beverage with your meal and then be done with it. But your sipping beverage should be something that's not going to sensitize the teeth, that you're adding a little bit, and you're adding a little bit, and you're adding a little bit to the teeth all day. And things that are there for a longer duration, like like a lollipop or a mint or a sucking candy. They're there for a long period of time. Those are really the things that are going to be cavity provoking. And the fruitier they are, the more they're going to promote tooth decay, because acids are sour. So a lot of times, if you're having some mango drink or mango coffee or mango thing, there's nobody shaving in the real mango into your candy. It's a flavor, and to make it flavorful, they add acid, because acids are sour. And there's been a whole trend in candy. Years ago, candy, wasn't as sour, but then they came out with like atomic warheads, like the soury sour stuff, and that is just more acid, so it's going to be more damaging. And you could see different patterns of tooth decay. If somebody has had an eating disorder, you'll see one pattern. A lot of times that's on the back of the upper front teeth. If somebody has acid reflux, you may see that on the back teeth. Candy, like a sucking candy, usually people store that in one spot. And so you'll see like a blowout of that tooth, like a really bad cavity, but just in one spot. And the rest of the mouth looks pretty good. Natural beverages, home brews, like homebrewed tea, homebrewed coffee, are they acidic? People say, well, those are acidic, doc, but they're not made in a factory necessarily, where they're concentrated and the flavor is really, really concentrated, so that people will just buy more of it. So usually like the homebrewed tea, homebrewed coffee, it's not going to be as damaging as something that comes out of a bottle or a can. And, for instance, something like Snapple or Arizona is much more damaging to teeth. And if you look closely at someone's teeth who really drinks one of those kind of beverages, you'll see that their teeth are not lustrous. They're not like shiny. They'll have like a dull, frosted appearance, because the acid is just taking the minerals out, and it's like a duller appearance. If you use a remineralizer, you may see that the teeth are more lustrous. And we'll talk a little bit about what remineralizers are. Next. So, and really what this all depends on is saliva. So saliva, what is saliva? Who ever thinks about what saliva is? The only time you really ever think about saliva is when you don't have much saliva and when your mouth is dry. Speaking of that, I'm just going to take a little bit of my fresh brewed delicious iced tea. So saliva is a mineral bath for teeth. And that's what keeps teeth healthy. Otherwise, we're eating tomatoes, we're eating food, and it's amazing that the teeth don't just dissolve away, in a short period of years. And yet there they are for decades. And what keeps them healthy is this really nice environment, this pH buffered environment that the saliva creates. And it's full of minerals. So let's say we did have some soda with really a lot of acid in there, like something like Mountain Dew, and it's going to pull the minerals out of the teeth. The saliva will recharge the teeth with minerals, but if we take another sip, then again the cycle has to start again. So actually, it takes maybe about a half hour for the saliva to repair the teeth, to recharge the teeth with minerals. What happens if you don't have a lot of saliva? Then maybe it's going to take much, 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 much longer. And I find that, so lack of saliva can be caused by loads of things: pain, chronic pain, depression, even just bad news. Like if somebody gets bad news, their mouth will just turn bone dry. So anxiety and all the medications that are given for these things will also reinforce the dry mouth. And the things that I find are really most damaging for people are opiates and things that are like amphetamines, medications like Vyvanse, what I find is a particularly destructive one. But anything that's like a real stimulant, it makes people's mouth dry. They don't have a lot of saliva, and they'll get a lot of tooth decay. And so then we really have it may be more than just brushing and flossing that that people need. Next slide. So it becomes really about understanding what the process is. So now that you know, now you can look at your beverages and you could say, ginger ale. You know, I leave that by my nightstand and I sip that in the middle of the night. I wake up sometimes, you know, my mouth is dry and I just sip that ginger ale in the middle of the night. Or sometimes people do that with Gatorade. So now you're coating your teeth with some acidy, sugary beverage. And in the middle of the night, like, you know, you're just not producing a lot of saliva. And that's why it's very important. Like if you feel, you should definitely brush and floss twice a day. But if you say, you know, in the morning, doc, I got to get to work. I'm just running out of my house. I don't have a lot of time. Really, the most important time is before you go to bed. Because when you go to sleep, and some people say, I'm so tired, I'll brush my teeth in the morning. But what happens is whatever's there is sitting there for another 6, 7, 8 hours. And that's where it causes damage. Anybody that's that may be like a homeowner, and you know, if there's like leaves against the side of your house and you just leave them there, you'll see when, you know, months later when you take the leaves away from the side of the house, that the siding, the wood is just damaged. So you never really want to leave stuff against your teeth. And a lot of times it doesn't really matter what you use to clean. Like if you just had a granola bar and you feel like some sludge, you know, in that pouch in your cheek, then just take your finger, take your tongue, whatever you have, just don't let stuff sit there. So if all you have is your finger, if all you have is a corner of a Post-it, whatever you have, just clean. Don't let stuff stay there. That's what'll really cause tooth decay, because the stuff that stays there acts like a sponge. So let's say, you know, there's a little something that stays there, like dried fruit or some bread or some crumbs or whatever. And now you do have an acidy beverage. So that little piece of bread that'll absorb the soda or fruit juice like a sponge, and it'll hold it next to the tooth. And that's where you're going to get tooth decay. So wherever you feel like, gee, you know, stuff is really just collecting there, that's something you really can't allow that to happen. So you really want to go to your dentist or your hygienist and make sure that maybe that some restorations need to be replaced, so they're self-maintaining. And you want to catch things when they're small. You want to catch things when it's just a little filling that, you know, there was some stuff, it was an open area and some stuff was packing in there, and you just get a little filling, and now it becomes self-cleansing. If you let it stay there, then now you'll have a gum issue. There'll be a bigger little hole to get some stuff. Maybe it's a bigger restoration. Now you need a crown. So you don't want to have this over treatment. You want to take care of things when they're very small, and try to find a provider who's really like a minimally invasive, non-invasive, conservative type of doctor. You really don't want an over-treater. I find that sometimes dentists, we're really looking for this kind of perfection that doesn't really benefit the patient in certain circumstances. And with CRPS, you don't want to involve yourself in a very long, very complicated treatment plan. You really want to keep things, unless you really need that, you really want to keep things as simple as possible and avoid invasive procedures wherever you can. So it's really about your nutrition, your home care, prevention, preventive appointments, and using the right products. So you want a toothpaste that has fluoride, and there's this whole other thing that the public really doesn't know much about, and that's remineralizers. So the product that I've been using for a long time, for over 20 years, that I've had tremendous success with, is a product that's available over the internet called M as in Mark, I as in Isaac, MI Paste Plus. MI Paste Plus. That's the one that has the fluoride. There's MI Paste, no fluoride. MI Paste Plus has the fluoride. And it's so easy to apply this. It's a product that's meant to be put on with your finger. And it's a milk-based product, and anything with milk, like ice cream, whipped cream, you put milk in cookies, cake, cream, it always tastes good. So it's not a bad tasting product, and you could swallow it, you could spit it out. Very easy to apply, and it's great for special needs care. People who, if you have dexterity problems, you have trouble really cleaning, this product can be very good. But a lot of products have remineralizers. So nowadays there are mouth rinses that have remineralizers, toothpaste. So look for products that have remineralizers in them. I happen to like the Act company. I find that they make products that really address the needs of people, and I know they have a restoring formula, mouth rinse. Crest has a remineralizing toothpaste. Sensodyne Pro Enamel is a good one. That's probably my favorite one. But there's nowadays a lot of products with remineralizers, and they do work. So if you see like a bleaching toothpaste or a whitening toothpaste, that's usually not something that works. It may just be something that is abrasive and removes stain, but it's not really like an intrinsically good, healthy product. But products with remineralizers, that works, and I would look for things like that. Next. So again, avoid overtreatment. Maximize your home care. That's where you're really going to get the value. Maximize your home care, preventive visits, fluoride treatments, and again, seek minimally invasive, non-invasive, optimize pain control, optimize your overall health, optimize your immunity, optimize your anxiety control. That's when you get your dental care. Next. So I do like and of course flossing. Now years ago, I would always use just the plain floss, and my wife said, try these little floss picks. And I said, honey, I'm the dentist, I'm the professional. The gold standard is dental floss. And of course, we go away on a trip, and I didn't pack my dental floss. So I tried some of my wife's little picks, and they worked really, really well, and she kind of converted me. And then one day, CVS kind of ran out of them, and I had to try a different brand, and they were terrible. So what I think is these little floss picks, they're really great, but you may have to go through a bunch of them to find something that works for you, that you have the manual dexterity for, that has the floss directed in the right way for your teeth and your hands. So you may have, and some of them, like maybe the floss is like very wide and thick. Other ones have, floss where it breaks really easily. So, you just have to try a bunch of them. And so spend a little time in that aisle. A lot of times, people will ask me, which is the best toothbrush, and I want them to get good products. I happen to like Sonicare, I like Oral-B, but find things that work for you, work in your hands, feel good on your gums, and again, sometimes my wife actually will just bring stuff home from CVS, and I'll try it out, and I've discovered some great things. But I kind of like the Oral-B, and an electric toothbrush is going to increase your efficiency. It's just going back and forth a little bit, and it helps the toothpaste get in between, around the gums, And then the other thing is that everybody loves to rinse after they brush. But, particularly if using fluoride in your toothpaste, or even a high fluoride toothpaste, or a remineralizer in your toothpaste, so now you're rinsing, and you're just rinsing it away. And even if you're using a really good mouth rinse that does have fluoride or a remineralizer in there, you're just rinsing away the fluoride and the remineralizer to put on more fluoride and remineralizer. So I'm not a huge fan of mouth rinses. I feel like you should brush and floss twice a day, and then in between, you're at work and you didn't bring your electric toothbrush and your dental floss, and you just want to freshen up, so you rinse to get stuff away from your teeth. Like really sort of try to like be irrigating your teeth and gums to get the rinse in between, in and around, and to sort of like get the stuff out, and rinse until you don't see stuff coming out. So let's say you had like some little thing with chia seeds or whatever, so rinse, and if you see some chia seeds, just keep rinsing. And then when you stop seeing anything come out, that's when you're really done with rinsing. So I think that rinsing is personally, my advice would be brush and floss in the morning and the evening. The really, really important one is before you go to sleep, and just use the rinse in between, kind of when you're on the go and you're meeting a new client, you're having people over, and you want to freshen up, but you really don't have time to go in and to go all at it, and rinse until you don't see stuff anymore. There actually are suction devices. So there's portable home suctions, and you can actually even get little brushes that go on the suction. And so particularly for special needs people, particularly if somebody is brushing for you or you have to brush for someone, a lot of times people with special needs, they really don't swallow their food the same way, and they have a tendency to leave stuff around their teeth. And now somebody has to clean for them or help them clean, and the person, particularly if they have dementia, something like that, they may be resistant. And so you're just, you're not, it's hard, they're not really cooperating, and you're just really sort of moving the stuff around their teeth, but you're not really cleaning it as effectively. But there are portable home suctions. A company called DeVilbiss makes nice ones. There's another company called Schuko, but I think I like the DeVilbiss a little better. And they actually make little brushes that go on the suction, so you could brush and suction at the same time. And instead of using a broom, it's like the invention of the vacuum, so it could be more effective. I think for most people, it's not necessary or applicable, but for special needs, it could be an extremely helpful, much easier way to do a better job. So, I'm kind of a biologist at heart. I was a biology major at Queens College, in Queens College of the city of New York. It was free at the time, and my father said that was our price range, so I went to Queens College. But I'm a biologist. I was a biology major, and so I'm into natural processes. So I like whatever, in all my therapies that I would recommend, I like to follow nature. And these are things that boost your immune system. These are things that boost your immunity, and also fight depression, which is common with people with chronic pain. There's one book, and interestingly, the pain pathways in the brain for chronic pain and depression, those neuronal connections in the brain are very similar. And there's a great book by Johann Hari called Lost Connections, and he discusses natural ways of improving depression, getting more sleep, good nutrition, socialization, as boosting your outlook on life. And I think that these are also things that would help for chronic pain. one really interesting thing that Johan Hari talks about is being around green. And there's another doctor that I follow, a pulmonologist by the name of Roger Schult. His name is spelled Seheult. Roger Schult. He's a pulmonologist, and he talks about what different ways in this whole COVID pandemic to boost your immune system. And he really gets very scientific. Everything that he says is really proven by research. So it's not really his opinion. It's all research based, and he really can get down in there into the molecular biology, and he really can identify this stuff. He's really very informative, but he doesn't really. I don't think he speaks over your head. So I think almost at any level you'll find value. But he talks about forest bathing, which is basically being out in green, being out in the forest. And my kids really laugh at me with this one. I tell them I'm going out in the backyard. I'm going to do some forest bathing, but it really comes from Roger Schult, and there's more information on this in the book by Johan Hari, Lost Connections. Highly recommend it. So one thing that may be effective for a lot of people with chronic pain with joint issues are occlusal guards. So there's ones you could get at your local drugstore. Those are usually soft ones, and then dentists make rigid ones, and the rigid ones are really much better. So what happens is it's a different neuromuscular pathway when something is slippery. So let's say you go outside your house or your apartment and you see it's very slippery. All of a sudden you instinctively activate different muscles, and you don't really use your big muscles. You don't use a lot of force. All of a sudden you really take care because it's slippery. So it's like an instinctive natural mechanism. The reason why I don't like the ones you get at the local drugstore are the soft ones, because they're chewy. And maybe for some people, I do have some patients that will say, yeah, I got one at the drugstore and it helped me. And so I wouldn't argue with that. But I feel like the chewy ones cause you to chew. And that activates the muscles. And it's like an overuse injury that you could get. Sometimes people will come in with real joint pain, and they can really be in a lot of pain. And I'll ask them, my first question is, do you chew gum? And very often they'll say, yeah, I chew gum. And basically it's just an overuse injury. They're chewing and they're chewing and they're chewing. The muscles, these small muscles, really start to hurt. So I really prefer the ones made by dentists because they're inherently rigid, they're hard, and so they're slippery. And you just don't clench on something slippery. You don't stomp your feet on something slippery. You use different muscles. So it's a different neuromuscular pattern. And this can rest the muscles. And so if you do have joint pain, then this is something that can help you. And but there's nothing magical about the temporomandibular joint, the TMJ. It's a joint like any other joint. If you have knee pain, shoulder pain, elbow pain, wrist pain, if you have joint pain, it's not unlikely that you're going to have TM joint pain. So that's really how we have to think of it. And the same things that help your other joint pain will probably help this, like rest. Sometimes NSAIDs like ibuprofen. In the NSAID group, I really prefer naproxen, because it lasts longer. It's the bottle, if you go to the pharmacy, that says all-day pain relief next. So all-day pain relief, that's the bottle. And people who have a long-acting pain reliever will have a better experience. So sometimes people will take ibuprofen, and when you take ibuprofen and you're really in pain, it really only lasts like 2 hours. So people will call up, they'll say, Doc, I'm in pain, you gotta see me today. I'll say, what are you taking? They'll say, I'm taking ibuprofen. I'll ask them, is it working? They'll say, yeah, but it only lasts 2 hours. You got to see me today. Whereas if I ask people who take something longer acting, like Aleve, which is the naproxen, They'll say, yeah, I took it this morning, but when I got home from work, I felt it again, because it's 8 to 10 hour pain relief. So I know very frequently I'll treat somebody in the morning and I'll want them to take another dose of pain reliever before they go to bed, because if they take the pain reliever, then they're going to think I'm a great dentist because now they're not having any pain. So if I treat them in the morning, I want them to take another dose before they go to bed. So I'll call them and I'll say, I want you to take to relieve. And they'll say, but I don't have any pain, because it lasts so long. It lasts all day. And that's it's just a different experience. So you want long-acting pain relievers. Now, the long-acting opiates are different. As much as possible, you want to avoid opiates. They're addicting. You may not feel good. They're very definitely damaging to your teeth. So when I treat a CRPS patient or a chronic pain patient, as I said before, in my field is really this acute management. And in acute management, you could afford to throw the book at the problem. You could use everything. And that's really where the success is, addressing as many things as possible to relieve pain. As if you had a submarine and you had this 5 screen doors in the submarine, and you want to close all 5 screen doors in the submarine. If you're only closing 2 or 3 of the screen doors, then the water's going to get in. So, and of course, hopefully you don't have screen doors on your submarine. But basically, the whole thing about pain management, effective pain management, is relieving as many pain pathways as possible. Next. So, from the National Institute of Neurological Disorders and Stroke, these are the drugs used to treat CRPS. Biphosphonates are kind of a new one. And I personally, they're really not for acute pain management. So these are drugs that I'm familiar with because they can cause necrosis of the jaw, but they're not drugs that I prescribe. The non-steroidal anti-inflammatories, the ibuprofen, the naproxen. My favorites are the one that works for the patient, because some people will say, bare aspirin is the only thing that works for me, or ibuprofen is the only thing that works for me, and maybe Tylenol never works for me. But sometimes it's what's in there. It's something you may not think of. For instance, I had a patient who said, I think it was Excedrin or bare aspirin, and they said, that aspirin is the only thing that works for her. And so we looked into it a little bit further, and interestingly, the product that she was using contained caffeine. And we ascertained that it was really the addition of the caffeine that was helping her. So sometimes caffeine does work for people, but it depends on what kind of pain you have. And one of the things that I think is very interesting is Tylenol. And a lot of people say Tylenol doesn't work for them, acetaminophen. But acetaminophen is really a centrally acting product. And I've had patients who have neuropathic type pain, and they said, oh, Tylenol doesn't work for me. And I said, you have neuropathy more than peripheral type pain. Try the Tylenol. And they were flabbergasted how well it really worked for them. So Tylenol, acetaminophen, is more effective for centrally mediated pain. So, and that's why it has some uses for postpartum depression and even relieving emotional pain. So it's an interesting actor. Another medicine that's not on here that I like to prescribe sometimes is Celebrex, Celecoxib. And the reason why I like to prescribe that sometimes, so the ibuprofen and the naproxen, they're not really they're COX inhibitors, but they're not really that selective. So the Celebrex is what's called a COX-2 inhibitor. It's more selective. And so it has less GI side effects, and it doesn't affect your platelets. So people don't have a tendency to bleed. So this is something, if you're on other medications, if you're on anticoagulants, you really need to ask your doctor about. But Celebrex, if you have GI issues, can be an interest, or bleeding issues, can be an interesting medicine. And it's kind of long acting, and I have very good results with it. Corticosteroids used to treat inflammation, swelling, edema. I use something that's in my treatment. I use dexamethasone, and interestingly, dexamethasone is in the news recently because they found that it decreased mortality in COVID-19 patients, and severely ill COVID-19 patients. But that's one of the ones that I definitely use. Getting back to the non-steroidal anti-inflammatories, I usually use ketorolac or Toradol, and I give that IV to patients if I'm using IV sedation, and that's extremely effective. So basically, every patient that I treat with IV sedation toward the end of the procedure, they get ketorolac or Toradol, and they get dexamethasone. And frequently, people that I treat that have chronic pain will tell me that they get 2 good days after I treat them. And I think it's because of that, the dexamethasone primarily, but also the ketorolac, which is a really great non-opiate pain reliever. And then, of course, there's all the other drugs that are given for neuropathic pain: gabapentin, pregabalin, amitriptyline, nortriptyline, duloxetine. So those are not drugs that I generally prescribe, but frequently people are on them. And so it may be that we up the dose if they're on a certain dose of gabapentin. I'll speak to their prescribing physician, and maybe we'll increase the dose of gabapentin beforehand so that we've prepped them even more. Botox can be effective. It's just not something that I do. But the other specialty that I mentioned, facial pain specialists, probably would do that for you. I don't really like to, or I prescribe limited amounts of, mostly what I prescribe among the opiates is hydrocodone. And I find that the hydrocodone is better tolerated by most people than the oxycodone, but some people will say, one really works for them and the other one doesn't. I do use fentanyl for acute pain management. So if I did IV sedation, rarely somebody will wake up in pain. Usually, if I'm using IV sedation, the last thing I'll do is give an additional dose of local anesthetic wherever I was working, so the patient wakes up numb but not in pain. It's really not a great thing for a patient to wake up in pain. So I want to cover them with that local anesthetic. And so my regimen is that they get the ketorolac and the dexamethasone toward the end of the case. But if they're still in pain after that, generally what I'll do is I'll get a pain score. So I'll say, what's your pain? The patient may say, I'm an 8. And then I just give them little doses, very small doses of the fentanyl. And I wait about 3 minutes in between doses for that to take effect. And when the patient tells me they went from an 8 to a 5, from a 7 to a 4 or 3, I wait for some break in that pain score, and then I stop. And interestingly, even though fentanyl does not really last that long as a sedative agent, people get once you relieve that pain, they don't call back a half hour later and say the pain came back. Once you break that pain for them, they're kind of comfortable. I do use Nmda receptor antagonists. The one that I primarily use, I don't use the dextromethorphan. I use ketamine. And I use lots of topical and local anesthetic, and I administer that very, very carefully. But ketamine, we're going to talk about ketamine, is extremely helpful medicine from a number of standpoints. So what medications work best to control pain for CRPS patients for dental care? Again, I work in acute pain management. So it's the opiates, the dexamethasone, NSAIDs, acetaminophen we talked about, anxiolytics, but also alpha-2 agonists. So what are alpha-2 agonists? So pain management specialists will use clonidine, or some will use tizanidine. So I mainly use tizanidine. Years ago, I used to use more clonidine, but the clonidine has a half-life of about 10 hours, and it's kind of long. Treating people acutely, I want them to, I don't want to give them a medication where maybe they're going to fall later in their apartment, or they're going to be dizzy, their blood pressure is going to be low. So I like to give people medications if they're in front of me and I could watch them. And so the tizanidine is something that's shorter acting. It has a half-life of about 2.5 hours. So depending on the patient, sometimes patients will come in and they're already on tizanidine, they're already on clonidine, or they're on something similar, and I won't add that. But I do use alpha-2 agonists like tizanidine, and there's another intravenously available medicine called Precedex. So I will use those medications. But what I really like to do is I like to use not one thing on this list and just rely on that. I use as many things on this list as I can in very small doses. So it's a very balanced approach where I'm not really using enough of anything to have a negative side effect, but I'm closing all the doors on the submarine, all the doors and windows on the submarine, so no water gets in, and that's really the approach. But I need to know how I'm treating them. In other words, maybe, next slide, maybe I'm going to be treating them with oral medicines. Maybe they've said to me, Doc, I don't need to go to sleep for this. In which case, I know that my drug list are things that I need to give orally. Or maybe very occasionally I'll use IM medications. So mostly it's oral, IV, and occasionally, very occasionally, intranasal. But intranasal can be a good pathway. Really, you have to assess what the needs of the patient are, and then decide what medications are available. So the patient may say, "Gee, doc, for this one filling, I don't think it's warranted," and I may agree with them to have, maybe it's not warranted to have the intravenous sedation. But if I am using intravenous sedation, then I have more medicines that are easy to give to someone. And the way that I do it is to give people every medicine, every little bit that I give somebody is a test dose. So usually I'll give people something to relax them before I bring them into the treatment room. Again, this is tailored to what their needs are. So they may say, if I'm treating anxiety, then I'm giving them usually midazolam or sometimes triazolam, and very often Xanax, which is alprazolam. So, I may be giving them something like that so they don't have the anxiety about the procedure. If I'm only using oral medicine, I may tell them to take a Xanax at home. I may tell them to take 2 Aleve at home before they come in, so that this way they're sort of prepped. They have a pain reliever on board. They have something for anxiety on board, and then when they come in, I could give them something else. If I'm giving somebody so much medication like that, we have to be careful. How are they getting home? You never would want somebody to drive home. So these are all considerations. What can I give somebody? Maybe there's no one that could take them home, no one that could stay with them. Maybe they're not that steady on their feet. I have to be very careful what medications they could get. So all these things are factors. So it's like a total, you really have to consider everything, and then know what the right method is for this patient. Next. So treatment options are non-pharmacologic and pharmacologic, but you always want to maximize the non-pharmacologic, because, and not to the exclusion of the pharmacologic. Like sometimes somebody just really needs some medicine, and if they need medicine, then you got to give them the medicine. But you could get the most out of the medicine at the lowest possible dose by maximizing the non-pharmacologic. So these things should work in tandem. And local anesthesia is really the mainstay for dentistry. When everybody, has the experience, they've been to the dentist and they get the numbing medicine. But it's not so effective for everyone. So one of the great things that's available is something called buffered local anesthetics. And this is something that's been around in emergency rooms for decades. I'm sure I heard of this 30 years ago. And basically what it does is the local anesthesia frequently has an acid in it. And it has the acid in it to make it more stable. So it could be shipped from China or the Philippines to California or wherever you are. So they make it acidic so that it has a shelf life. But you can imagine if you're injecting something that's a little acid, it's going to have an ouch, right? So buffered local anesthetics have less ouch. The other thing is that buffered local anesthetics are closer to our own natural acidity. And so they work better. Buffered local anesthetics work better. So there's a number of products on the market that can help a dentist give a buffered local anesthetic easily. And basically for every single one of my patients that is awake, if they're having intravenous anesthesia, I usually feel like they don't need it or they wouldn't notice the difference. But if they're awake, every single patient gets a buffered local anesthetic because it works better. And I know that because of who my people are who come to my office, that they have difficulty going to the dentist, I'm going to assume that they're in that 5% who have trouble with local anesthesia. And there's no downside to buffering the local anesthetic. It just makes it work better and faster with no downside. So I use it on every single case. And but once you put in that it's basically bicarb, just like the Arm & Hammer bicarb that you put in your refrigerator so it won't smell. That's what it is. It's just bicarb. And but once you put that in with the local anesthesia, the shelf life now is maybe just a couple of minutes. So my assistants know the product that I use is called Onset, and they'll say Onset. I'll say yes, Onset, and then they it's a little pen. They put the Onset into the local anesthetic. They hand that to me, and I use it right away. So that's a great thing. So you can have regular local anesthesia, but you could make it a lot better, and you could use non-pharmacologic things. We do like we try to decrease the stimuli. We give everybody sunglasses because who doesn't feel good when they're wearing sunglasses? But it decreases the visual stimuli, and we lower the lights in the room. We can use noise canceling headphones. Mine disappeared during this pause, but I'll get another pair. They're very helpful. Another thing we could use is nitrous oxide, laughing gas. And the thing about, so the interesting thing about nitrous oxide is that it is also an Nmda receptor antagonist like ketamine. And I thought maybe that people would get the same type of effect with nitrous oxide than they do with the ketamine, but I don't think that it really works like the ketamine. So I haven't found that it does, but it still can be a very good agent. And primarily what it does, it's a really good pain reliever. So if you're not having intravenous, it's a good pain reliever to add into the mix, into the recipe. So oral medications, we talked about. We can give hydrocodone orally, and that's a great pain reliever to give a patient before an arduous, potentially painful dental procedure if they're not going to sleep. So they can get hydrocodone, they can get Xanax, and sometimes when we combine these medications, or we give an increased dose, so we call that oral sedation. And another great medicine for oral sedation is called triazolam. And you probably can find dentists that give triazolam. It's pretty common, but you just want to find somebody with a lot of training. You wouldn't want to go to somebody who hasn't done a lot of cases. And that's always a great question to ask. How many cases have you done? And really you want somebody that's done thousands of sedations. You want somebody that's really experienced. If they're not board certified in some type of anesthesia, like the American Society of Dentist Anesthesiologists, or there's a similar one, the American Dental Society of Anesthesiology, if they're not like really boarded by one of those organizations, or they don't have extensive residency training like a dental anesthesiologist or an oral surgeon, then you really have to be careful how many cases, how much experience they really have. And again, you want somebody who's done thousands of these cases. Particularly if you're having IV sedation, then you really would want to go to somebody who's boarded in oral surgery or by one of those organizations that I mentioned. And there's also general anesthesia. And now I've done many, many, many types of sedation, general anesthesia, deep sedation. I've probably done more than 15,000, probably less than 20,000 cases like that. But in my experience, for the most part, patients don't need general anesthesia. It's just more than is needed. So IV sedation is great, oral sedation is great, and all these other modalities can be very good. And you really want to talk to your provider, really go through it, what your needs are, how you feel about it, and and what you feel you need. Next. So ketamine. So ketamine is a super interesting medicine. I'm sure you've probably all heard of ketamine, and you've probably placed a lot of hope in ketamine. And whether or not it works long term for people with CRPS, whether it helps or it doesn't help, there's a lot of debate about that. It probably helps some people really well, and some people it doesn't help. I think is probably the bottom line on it. But for acute management, it's incredibly helpful, because sometimes people are on a lot of medicine over the years, or just the way their metabolism is, they really can kind of be resistant to other sedatives. But ketamine is a little different. When ketamine, if you give somebody ketamine, they get very good analgesia. It's really an excellent pain reliever. So that's why I use it for almost all my intravenous cases, and occasionally I will give it orally. One of the things about ketamine, it doesn't, the sensorium, like if you give somebody something to relax them intravenously, and they kind of feel that medicine, they're usually very good feeling medicines. But ketamine is a little different. So usually, and so sometimes people may not like that feeling of the ketamine. So if I give ketamine, I'll always mask how they feel with something else, so that they're feeling like very relaxed, and then they could get the ketamine so that they feel comfortable with it. So, and I usually use, for an IV sedation where I'm using it as an adjunct, it's usually about 0.5 milligram per kilogram, which means that people would get like 30 milligrams, 50 milligrams. And that seems to be, when I read in the literature, that it's sort of consistent with ketamine clinics and or so. But sometimes, it has other uses in sedation anesthesia, so sometimes we use it at much higher dosages as well. But you could put it, you can use it orally, intravenously, intranasally, phenomenal short-term pain control. And it has benefits. It's probably the #1 drug for acute management of depression. And many of my patients do suffer from depression. They're typically, a lot of my patients are post-traumatic stress of one type or another, one level of severity or another. So the ketamine addresses the depression, it addresses chronic pain, and even single doses of ketamine at the time of a procedure have been shown to have long-term effects. So it's very, very, very useful in dental sedation. Very, very, very useful, very helpful. With CRPS, patients, this is a number of studies. So ketamine was found to be successful in reducing pain and blocking spread in severely affected patients. And so there was an infusion protocol which also included an alpha-2 agonist. It included clonidine and midazolam. And patients were given ondansetron, which is Zofran, for nausea. Generally, with just these medications, ketamine, clonidine, and midazolam, I don't find that these patients get nauseous, but it's certainly not a lot of downside to giving the Zofran or the ondansetron. So ketamine, it's in the literature, was found to be successful in reducing pain and blocking spread. So that's great. And it could be used orally, which is wasn't studied here, but it's very, very easy to do. So you could put ketamine in. Usually, I put ketamine with a little midazolam. So oral midazolam, it's like an elixir, and I'll put a little ketamine in there, and that's the oral elixir that I would use. And sometimes I would use tizanidine as well. Next. So we said we wanted to optimize patients beforehand, so that includes NSAIDs, the Aleve, Celebrex, anxiolytics, antibiotics. If somebody has, if somebody's tissue is really inflamed, like for root canal or gum treatment, I will use antibiotics beforehand. I do try to limit how much antibiotics that I give. I don't want to overuse antibiotics. There's good bacteria, there's bad bacteria, and you don't want to knock out the good with the bad. And there's good gut bacteria, there's good skin bacteria, and we live in symbiosis with these bacteria, and so we don't want to knock off the good ones indiscriminately. This is a really important emerging field in medicine, the biome, and we're said to carry around with us 3 to 4 pounds of bacteria on and in our bodies. Cannabis is a good medication, and I would much prefer, from a dental standpoint, that somebody use medical cannabis to opiates. Much prefer that, and I think that it could increase range of motion. We can't say that it's absolutely not addicting, but it's certainly a lot less addicting and habit forming than opiates. So it has a lot of benefits, and I'm very much in favor of medical cannabis. My concerns about cannabis are that they'll make it too potent, they'll make it too good, and so I think anything, if it's too potent, can change it. So it may not be your grandfather's marijuana anymore, but now it could be something that could be a different thing. It's too potent. So so everything in moderation. But I think it has a place in relieving neuropathy and range of motion, and it could help people where other things just haven't helped. They may have tried muscle relaxants and things like that, and I think it could be a great drug. I'm not really so much in favor of my patients having medical cannabis and then coming in for an appointment immediately after. Because I think it's a little unpredictable for me. I'd rather use anxiolytics probably, like Xanax or triazolam. But I think it definitely has a place in pain management. Patient positioning. You want to make, again, this is a non-pharmacologic modality, and you want to make the patient comfortable. So I definitely use a variety of lumbar supports and cervical pillows, and egg crates maybe under the egg crates are that foamy stuff that you sort of looks like you could put eggs in it. The little, it's like that irregular little depression thing. So anything that provides a little extra padding, maybe some elevation of the calves, take some pressure off the back. So you want to make sure that the patient is comfortable. And one of the things that you want to be concerned about, so patients with CRPS is so sensitive positionally, and they may be turning to one side toward the dentist for a long period of time, sort of looking up and to one side, because that's where the dentist is, and the dentist has them positioned that way. But I think periodically, maybe every 10 minutes or so, you want to just be able to really like relax your shoulders, maybe move your head around, just so that you're not getting any nerve impingement. Post-op pain control. Again, I'm very in favor of cannabis, but I would be very careful combining it with other things that may make somebody too dizzy. And I'm always very, very, very concerned with people falling. So that would be a number one thing. But we talked a little bit about the NSAIDs, opiates, the special role of acetaminophen as a centrally acting player, and gabapentinoids, very good for neuropathy, and alpha-2 agonists. And the alpha-2 agonists just don't make somebody as sleepy, and that's really, really very good, especially if I'm going to be providing sedation for a patient. So I always want to get the most from the medicines that I'm using, but not necessarily have the patient too deeply asleep or over sedated. So the alpha-2 agonist, the tizanidine, is not particularly sedating, but because it's pain relieving, it's a great adjunct. So I like that a lot. So it's a comprehensive approach, multifaceted, multimodal. We're trying to take into account the entire needs of the patient and all the modalities that we could bring to bear. Okay, and just in terms of wrapping things up, resources and finding a dentist near you. So these unbelievable. We have 2 new dental specialties that deal with pain for patients, deal with anxiety and pain. So I would look for these credentials if you're looking for a healthcare professional, because many people might say that they do this or that, but you really want to go to somebody who's credentialed and who's been through a learning program, and this is really what they do. So I think that's these are some very, very, very important resources, and this is who I am. And again, I'm just happy to help people. So if anybody wants to contact me, I'm very happy to help and just point you in the right direction. If we get an overwhelming number of inquiries, I may have to maybe a little slow getting back to people, but I'll really do my best. But by all means, I'm happy to help. So please feel free to contact me, even in the future. And one of the things that I find that I didn't mention anywhere in the presentation, but I think is such an important thing. And remember that I deal primarily with people who had some trauma in their background, and many people feel like some sense of embarrassment about their condition. And I always tell them that you never have to be embarrassed with me. But I think that try to unplug that for yourselves if you can. I find that is it doesn't relieve anxiety to judge yourself. So just try to let that go. Forgive yourself. And the other thing that I would say about relieving anxiety, so it's sort of a natural thing for people to assume that the emotional is preventing the physical. I feel this way, therefore I'm going to do or not do this other thing. But the very interesting thing is that the physical often controls the emotional. So, in other words, taking some action step to help yourself actually relieves anxiety. How many people will say, I feel so much better after making the phone call or after telling so-and-so how I really felt. They feel better. So the action actually, that's the mechanism in the brain. The physical action helps the emotional. So that's what I would say. And the last thing I would say is that if you, I'll always have one more thing, but the last thing that I would say is that now is the time with COVID and what we're facing to be healthy. So I'm not saying, if you always wanted your smile fixed, now's the time. That's not what I'm saying. What I'm saying is if there's some chronic condition, a gum condition or a root canal condition or something that's been hurting you, now would be the time to take care of that, because you just want to be healthy now. You just want your body not to be fighting some dental infection or gum infection. You just want to be healthy now. And that's what I would reach out for. And, they're talking about, a second wave or whatever. If things are good in your town, in your community, that would be the time to seek care. And again, it doesn't have to be fancy aesthetic care, just basic care. Just be taking care of yourself at this point in time. I feel very blessed that you guys gave this opportunity for me to talk to you all, and I really thank you for that. And that's all she wrote.
Well, all right. I have learned so much through this. This has been absolutely awesome.
All right, but Alexis, you have a beautiful smile.
Thank you. Thank you.
Yeah.
I really appreciate that.
Oh my God.
So we do have a few questions that have come in. If you have a few extra moments, I know we had a question from someone who mentioned pre-op antibiotics. So, what is a good alternative for someone who may be allergic to penicillin?
So usually the two are penicillin and clindamycin. So a lot of times root canal infections and gum infections in particular, it's clindamycin. I find that when you go up in spectrum, like Augmentin, it knocks the crap out of people sometimes. So I try to stick to I find the amoxicillin is generally the best tolerated, but my number two would be clindamycin. But you just have to be careful if you do get diarrhea. Sometimes these things happen. Or but also makes you your skin photosensitive, so you can't go in the sun with that.
Another question we had was about dental implants. What are your thoughts about getting dental implants if you have CRPS?
So here's the interesting thing about dental implants. So you stub your toe, man, you're gonna feel that. You're like, oh my God, that hurts so much, because your toe or your tooth is a natural nerve supply that goes from that tooth to your brain, and you feel that. It's sensitive, you feel that. But interestingly, once a tooth is out, it's sort of like a generic area, and there's not as many nerve endings. So implants are really not sensitive. But that being said, I would not take out a good tooth or a salvageable tooth to put it in an implant, because logistically it's a lot to go through. It's an expense. It has to heal. So, and there's time involved. It heals for 4 months, and then you get the implant, and that's going to heal for a while. So save your teeth, take care of your teeth. But if you do need an implant, it's less sensitive than a tooth is going to be.
I'm trying to look through and see if I've missed any comments or any questions. Jen, did you see anything else?
Someone was just asking, Dr. Siegelman, for like a normal procedure, like for cavities, would you be recommending an antibiotic if someone has an immune system that's been compromised?
No, because you could create resistant strains. In other words, you give somebody an antibiotic that they didn't need, You're going to kill off almost all the bacteria except for the bad ones, the really bad ones that are resistant to that bacteria, and now resistant to the antibiotic, and now those could grow. So you never want to create resistant strains. And so we should be careful about the use of antibiotics. We want to treat things with, naturopathy, irrigation. You want to clean, irrigate. You don't want things to lay there. But as much as you could avoid antibiotics or use local things like inside the tooth. One of the things that I do for a root canal is laser disinfection. So use a laser to disinfect inside a dead tooth. You could use antibiotics that go inside the gum instead of taking an antibiotic and only getting a little bit around the gum. You could just put a little bit of time-released antibiotic gel by the tooth, or use a laser by the tooth to disinfect without taking the antibiotic. So always, minimal intervention.
Great answer.
Yeah.
I wanted to thank you. People are just amazed on what a caring, compassionate man you are, and I know when
you're going to embarrass me.
When you return from vacation, there's going to be a boatload of people from Philadelphia coming to see you.
Okay. All right. Yeah. Go Philly.
Yes. Well, before we end, once again, I definitely want to thank you for all this great information. As always, everyone, if you're watching, we will have this video pinned to the top of our timeline for easy access if you want to rewatch it. We're also going to add it to our YouTube channel. And of course, the presentation is already on our website. So if you're looking for that, we can send you the link. Just send us a message. And once again, if you have questions for us, if you need a support group, if you're looking for a new physician, if you're looking for a face mask, we have face masks, y'all.
Oh, cool.
Definitely send us an email, info@rsds.org. Of course, like I say, you can send us a message. We're here for you. Let us know how we can help. Y'all have a great evening.
Thanks again.